Welcome to the Mental Health Book Club podcast with your hosts, Sydney Timmins and the Secret Psychiatrist. We would like to take this opportunity to let you know that we will be covering a diverse range of mental health topics that may be distressing to some listeners. You can find a full list of the topics being covered in our show notes. Please check the show notes before listening to any of our episodes. Welcome to the Mental Health Book Club podcast with me, Sydney Timmins. And today I'm extremely happy to welcome back again to this podcast, The Secret Psychiatrist. And as a result of reading The Clown and I by Ryan Heffernan, today we will be speaking about bipolar affective disorder.
Hello, I'm the Secret Psychiatrist. I'm a psychiatrist in London under the NHS, and I work with mental health from children all the way to old age psychiatry individuals. And you can find me on the Secret Psychiatrist on my website, Twitter, Facebook and Instagram.
Thank you and welcome back. How are you?
Good. I feel like I'm a rash you can't get rid of. I'm always coming back.
Oh, we love this. This is good. Keep coming back.
I'm not going anywhere.
So I personally don't have any real knowledge of bipolar affective disorder. I have not suffered with this particular condition myself. So I'm going to find today very interesting by talking to the Secret Psychiatrist. And as always, what I will do is I will start off with the book blurb. For those that have read the book, this would just be a quick recap. And for those that haven't read the book yet, you'll get a feeling for what this book is about. So, Clown and I is a dangerous, steamy and soulful memoir from Ryan Heffernan, a man with bipolar disorder. Ryan really should have lived in another time. International celebrities get sweaty and spanked, and life can be grandiose. But personal ruination forever lurks in the confronting exploration of how one man tries to fit in and make sense of the elusive real world. Laced with love, lust, heartbreak, bad boozing and poverty, Clown and I is a one-of-a-kind entry from a man in this genre. It is a dreamy and philosophical global odyssey, a diamond sparkle, spiritual and central insight into bipolar, stormy personal relationships, and the hard, street truths of dicey mental health in a society that won't always yield. But hope, beauty, dream chasing, and Ryan's wondrous son are the undisputed emperors in his eccentric universe. This is one little boy laid bare. So that's the synopsis.
Firstly, I love the title of the book. It's
good, and you should also see the picture on the front of the book. Ryan has a picture of himself with one half of his face without any face paint on, but the other half of his face, which is painted up as a clown.
So he's clearly trying to show sort of manic state in the clown, it sounds like.
So. I think one half is depicting the mania that he goes through, and then the other half would, I guess, be what he would consider his normal. So what can you tell me about bipolar affective disorder?
Yeah, so bipolar affective disorder is, I always see somebody whenever I'm working in clinics or in the hospital, somebody with bipolar affective disorder, just as with schizophrenia, I see it quite often. And on a personal note, before I talk about all the factual information, I was just remembering my very first case, and I'll never forget it, of someone with bipolar disorder. And obviously I won't go into the details for confidentiality, but what I can say, she was very intelligent and she was going through a manic state. So she was speaking like this really, 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 really quickly, and I couldn't keep up, and it was just constant like this, and my head felt like it was also shaking trying to listen to everything she was saying. And I found myself at times speaking really, really quickly as well, because I was so swept up in her energy. And it's something we call pressure of speech, where you can't really interrupt a patient in this manic state because they're speaking so fast. Now I feel like I'm speaking really fast talking about bipolar, and they have these flight of ideas, so they get swept up about talking about different things almost in one sentence. So it's like, I always think of it when you're reading a novel and you come across an author that for some reason does not like full stops, and sometimes it feels like an entire page is one sentence without a full stop. That always makes me think of bipolar and it being in a manic state, because there's no breath, there's no sort of natural pauses, it's very constant. So I'm going to give another example just so you get the picture. I went to the football stadium the other day, and then I saw my mum with ice cream. Wow. And then I went home, and then I booked something online. And I went to Amsterdam, and I'm going to university next week. So really very quick, almost like a train going on totally different paths. So that was the first case I had of her. And so I was particularly drawn to this case because possibly it was my first time I'd ever seen bipolar disorder. And because of the energy that this patient was giving out because of her manic state. I found that quite exciting as a psychiatrist to witness. But that was just as a side note of a case story.
I know that I met people that have bipolar affective disorder, but as a result of that, I haven't necessarily seen them in what would be identified as a period of mania. And just having that short little snippet that you gave just then was really interesting, particularly because I have not been there, I've not been through this. And to be honest, I am kind of taken aback by just how much energy and how difficult it would be for that individual to be able to continue at that high level of mania for such a period of time, because I'm aware that there are times when this can last for a good chunk of time. Also, it must be really difficult for those individuals around that person, because whilst that person may not have identified that they are in a period of mania, those around them will definitely have noticed and will probably find it pretty difficult to deal with. So is there a possibility, so would you be able to just give me a bit more background about the symptoms and what a person with bipolar affective disorder would likely to experience?
So let's talk about the facts. So what is bipolar affective disorder? So classically, it's periods of prolonged depression alternating with periods of excessive elevated mood, and that's what we call mania. So for those that just like to have slightly more information, mania is when you have approximately 7 days of elevated mood, okay? And sometimes when I'm talking about bipolar in this podcast, you'll hear me say hypermania. Okay. And the difference between that is that's 4 days of elevated mood. So just keep that in your mind when I'm talking in this podcast.
Right, okay. So mania is an elevated mood for 7 days or more, and hypermania is elevated mood for 4 days or more. So, I've got a quick question. I've heard that there are 2 different types, or there are several different classifications for bipolar affective disorder. I know that there's bipolar 1 and bipolar 2. I was wondering if you could go through the classifications.
So, typically there's a type 1 and a type 2. So, type 1 is when you have mania or mixed mania and depression, and that needs to be approximately sort of 1 to 2 weeks with the depression if you're having that with that. And type 2 is when you have depression and hypermania. So the first one's basically, remember, it's got mania in it, and the second one with hypermania. Okay, so you need at least 2 mood disorders with complete recovery in between each, in a way, relapse for diagnosis. If you're using, so in the UK we use ICD-10, and some also use DSM as well. So that's just criteria that we use as psychiatrists.
Okay, so just a quick recap. The ICD-10 is the International Statistical Classification of Disease and Related Health Problems, which is in its 10th revision, and that is published by the World Health Organization. And ICD is the foundation for the identification of health trends and statistics globally, and the international standard for reporting diseases and health conditions. And the DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, which is another classification system.
So for ICD-10, you need at least 2 with complete recovery, whereas in DSM, you can have a single manic episode to be diagnosed with bipolar affective disorder. So naturally, as I said, mania is for 7 days, and naturally, mania can last for about 4 months if you don't have any treatment.
Wow, I'm going just 4 months in a constant state of...
Yes, can you imagine?
I couldn't. I mean, that little bit of you just speaking really, really fast, I was like, whoa, whoa, whoa.
I know, I'm taken aback.
I mean, that's just incredible. 4 months.
4 months, exactly. And with the depression, that can last 6 months if you don't get any treatment either early on.
So what happens if the individual does get treatment for their bipolar affective disorder?
But if you do get treatment, which I'll go into later, you can actually resolve your symptoms completely within 3 months. So that's how much it can make a difference if you get the treatment early on. So let's talk about mania in slightly more detail about what it is. So as I said, it's an increase in mood. You get an increase in energy. So like I said, that can be shown objectively when I'm talking to a patient by their pressure of speech, their flight of ideas, which I showed you. So it might be that you've got increased self-esteem, and you can sometimes see people writing grandiose. So that goes with high increased self-esteem. So it might be you have a patient who is grandiose, meaning, say for that particular patient, they think they're the queen. They think they've got supernatural powers. They think they're Wonder Woman. They think they're very special for some reason. So that's what grandiose means.
Okay, that makes sense. I mean, at one point in The Clown and I, Ryan says to his psychologist that he doesn't think he is God or anything. So that is what you would characterise as grandiose thinking. But I can see why this would make people find it difficult to relate to the person who is going through a period of mania, particularly if they are having these grandiose thoughts that they are God or they are the Queen or they are something really important. And for everyone else, clearly that is not the case. And I'm guessing that kind of behaviour is one of the most trickier ones for other people and society to deal with. I mean, in this case, he's kind of saying it quite flippantly, I don't think I'm God or anything. And in some ways kind of showing his own stigma towards bipolar affective disorder. And it is clear from what he's saying that the reason for this stigma is because he doesn't necessarily understand the condition himself at this point.
And you might also see objectively what the patient dresses. So I remember when I was a medical student, I saw a patient, and now when I reflect back, I realise that this patient had bipolar, but I didn't know at that time. So I had a patient that had multicoloured hair, but very, not in a fashionable way. It was just all over the place, potted around, and was wearing half sunglasses and half normal glasses on her face, kind of glued together. And she was wearing an array of mixture of clothes that just did not make sense. So it would be like Wellingtons and a slipper. It would be the brightest pajama trousers, the oddest top, and a fake bird attached to her shoulder. So she was, when I look back, I realised she was in a manic state, and objectively she was wearing all these excitable clothes in a way that just wouldn't go if she was at her normal baseline. So there's certain things you can see just objectively with patients. That doesn't happen with all patients, though, to keep in mind. Also in mania, you might have reduced attention, so they're very easily distracted. They might have behavioural issues, which can be dangerous actually long term, such as overspending. So a trigger warning is if I have read on the notes that a patient has spent £1,000 on online shopping suddenly, which is very out of character for that person. I mean, some people spend, lots of money on shopping, that's fine. But if this is very out of the blue, out of character for this patient, suddenly spending so much money, and then you're worried about debt, then that's something perhaps that patient's relapsing.
Yeah, I mean, the money part, we see that when Ryan is talking in his book about one of his manic episodes, where he goes out and he decides he needs a whole new wardrobe, a whole new look, and he dyes his hair, and he goes out and he spends all this money on what he describes as cowboy and British mod. And he has to have these cowboy boots, which are $450, at a time when he doesn't actually have the means to pay for it because he doesn't have a full-time job anymore.
Also, it interferes in social functioning. So there might be issues, say, if you're at school or at work, that this is impacting your life as well. So hypermania, as I said, is 4 days. It's very similar to mania, but the difference is, apart from the 4 days, it doesn't interfere with your functioning, your social functioning. So it's milder than mania, if you like to think of it that way. Now, some of the other subcategories I wanted to touch on as well is cyclothymia. So what that is...
about that, yeah.
Ah, there we go, perfect. So this is when you get periods of hypomanic symptoms and periods of depressive episodes for approximately 2 years. And that's why it's different to bipolar. Now, the other subcategories as well, you might have heard of rapid cycling. What that is, it's when you get 4 episodes of mood disorder, of, the manic or depressive in 1 year. Now, this is typically present in women. It's approximately 80% of women, actually. And this could also, you need to keep in mind, could be due to medications. So if you, for instance, if you're taking steroids or if you're taking certain medications that can increase your risk, then that's something to keep in mind, that you might be rapid cycling. Another subcategory is postpartum onset, so after pregnancy. So
we have a book coming up on that, actually.
Perfect. So I can go in much more detail in that book then. Good. This refers to the onset of hypomania or mania or depressive episode with about 4 weeks of childbirth. You might have also heard of seasonal pattern. This is when you get recurrence over years, sort of the same time throughout the year, where you're more likely to get mania a certain period of the time, or depressive episodes. And the last subcategory I want to talk about was secondary mania. So this means you're getting mania secondary to something else, because of something else. For instance, if you're using steroids, so you can get steroid-related mania. Okay. Now, also, you might have heard, actually, I'll just quickly touch on this, bipolar 3. So what This describes minimal sort of depressive episodes complicated by antidepressants and induced hypomania. So it's in relation to a medication that you're getting these symptoms. So there's lots and lots of different diagnoses. Obviously, assessment takes time, and it's over a period of time to be correctly diagnosed.
Yeah, I was just going to say, you're not necessarily going to be able to put people into the correct diagnosis with just like one visit or something, are you? Really?
Absolutely. It has to be a period of time. So let's talk about the genetic factors. So genetics, I always feel, has a contribution to quite a lot of things. So your risk of having bipolar is increased, especially if you're a monozygotic twin, so if you're identical twin, and that concordance rate can be about 70%, so it's quite high.
That is incredible. 70%. Wow.
Yeah. And also, say I'm a mum, if I have bipolar and my partner has bipolar, the children that we might have a 50% chance of also having mental health. Not necessarily bipolar, but of chance of having mental health.
Some kind of.
Exactly.
How interesting.
And in particular, the lifetime risk of first-degree relatives of bipolar mood disorder in patients is 25%. What first-degree relatives is, for those that don't know, is so like your sister, siblings, parents, children, sort of the first tree link, basically, of genetics. Right. So that's 25%.
Wow.
Now, also in genetics, there's certain polymorphisms of the serotonin 5-HTC. I'm just going in detail for those that want it. If you don't want it, just don't listen to this bit.
Yeah, I'm really nosy. Yeah.
I know you like it. Yeah.
Sorry, people, I like this bit.
And the 5-HT transporter protein are associated with affective disorder. What this basically means in layman terms, because I don't want to get, for those that don't know, this means there could be differences in the serotonin transporting system. So serotonin affects your mood. So if there's polymorphism, sort of differences, then that can affect having possible affective disorder genetically and associated with that. Of note as well, substance abuse. So people with bipolar are more likely at high risk to use substances and therefore might have relationship problems and perform poorly at work. So it's very worrying if someone with bipolar is dabbling in substances, because it can lead to a poorer prognosis.
Yeah, I mean, in the book again, we see this for Ryan, that there are times when he does misuse substances, and that seems to be, during those times, it makes his life even more chaotic than before. And there are times when he did go on drug benders, and as a result of that, his mental and physical health seemed to suffer significantly, particularly in what he writes in his book. Well, substances and mental health don't really mix, and I think that's probably a big important thing to stress. Substances that are not prescribed by your doctor and mental health don't usually mix very well. And I guess the next thing really is treatments for bipolar. What is available for people with this condition?
Now, treatment, it's lifelong, okay?
Right, yeah.
Not curable. Like with everything, you've got to manage it. As I always like to refer to physical health problems like diabetes, you've got to manage it. Okay, You've got it. You just control it. So again, it's lifelong, and relapses can occur, and that needs to keep kept in mind. You need to be aware of your triggers, and that can be done with yourself, your therapist, or your doctor.
I guess that identifying triggers is going to be quite tricky, particularly for you if you are not necessarily able to identify the changes in your own mood. And so I guess that's where your therapist can help. I know from others that I've spoken to about this that they don't necessarily see it when their mood changes until someone points it out to them. And so remembering the points and the changes in mood and what has triggered that is not necessarily easy for them to do, other than taking a retrospective look back. And we see that again with Ryan, as he spends quite a lot of time thinking about his life and identifying what things may have triggered him to have his periods of mania. And one of the things that he identifies is travel. And it seems that every time he goes on some kind of trip where he has air travel involved, there is a particular period where he goes through a highly difficult time with mania.
So good treatment plan includes sort of a combination really of medication and psychotherapy related treatments. Can be cognitive behavioral therapy, interpersonal therapy, family therapy. And some of the different treatments you can have, they can be a mood stabilizer, so obviously stabilizes your mood, can be atypical antipsychotic, so it's an antipsychotic because sometimes in bipolar you can have psychotic features. So sometimes that's why you can't diagnose it as a practitioner on the first offset, because because you might think this person's got schizophrenia, which I'll talk about in another episode.
Right.
Because you might get psychotic features, especially if you're manic, because you're grandiose. You might be saying, I'm superwoman and I do this and I have this power, I can read your mind. And so you don't quite distinguish, is this schizophrenia or is this bipolar manic episode? So you can be treated with atypical antipsychotics depending on your symptoms, as well as antidepressants, obviously, if you're having depressive episodes. So some of the medications, and I can talk in another podcast all about different medications and specifically how they work for those that are really interested. So some people might be on lithium, valproate. I mean, the list is endless. Aripiprazole, risperidone. I mean, it goes on. So there's lots of different medications, and it's really finding what's best for you and your health. Now, I wanted to touch on ECT. So this is electroconvulsive therapy. Now, the reason I mention this, in very severe forms of bipolar, you can give ECT if all treatment hasn't helped, and it's sort of like a last resort, really. Now, for those that don't know, and I'm laughing here because has anyone, I wonder, watched
One Flew Over the Cuckoo's Nest? I think that's one of those iconic films that doesn't necessarily portray mental health in the best light.
And they I laughed because it was so incredible when I watched it, because I couldn't believe that they were making a film like this. But basically they tried to show ECT, and they showed it in a very brutal way, that someone's getting essentially like electrocuted. Okay, and that's what people think when they think of ECT, that you're putting panels to your head and electrocuting somebody. And I mean, that's actually what my parents thought because I've done ECT on patients, and it's not like that. But I remember when I was discussing with my parents, that's actually what they thought. And I think that's quite typical. People think,
I think so.
That's what you do. So I wanted to kind of talk about this. So that's not what happens at all. So ECT was sort of developed in the 1930s, and it's really been modified in a very safe environment. Certain outpatient clinics, and not many do this ECT. There are, I know two in West London that do ECT, and I've done it myself. So what this involves is, so if you've got very severe form of mental health issues, including bipolar and certain diagnoses, you come in and you're assessed. It's all very controlled. You'll have an anaesthetist, and you'll have usually one or two doctors there, as well as the nursing team. And it's sort of it looks like a tiny little ward, actually. It's got a bed, it's got everything there, oxygen, whatever you might need, emergency treatment. And essentially you're sedated. You're not under extreme general anesthesia or anything, but you're sedated so you're comfortable. And 2 panels are put on the side of your head. You might have 1 panel, depending. When I did it, I put a panel on each side. And essentially what you're doing is you're inducing a seizure. And the reason you're doing this is because there's research that goes that ECT can help with the blood flow and possibly help with the growth of new cells. And there's much more research trying to understand ECT exactly, but it's been shown to actually help patients. And you can have this for a few months, really, once or twice a week, depending, everyone's different. But it's in a very safe environment. Doesn't last long at all, like a few seconds, really. And the panels are taken off. So after a few seconds, when the seizure recording's seen, and then you're taken by the anaesthetist and comfortably brought round again. But it's very, very safe, and it's not, as that film showed, you're not shaking, you're not awake, you're not in pain. It's a very comfortable procedure, and it's been had good success rates, actually, and patients keep coming back and back for it because they feel like it does help them. So that's something I just want to touch on, because it has a lot of stigma towards ECT, actually.
Huge stigma.
And if anyone's listening and has had ECT, I mean, I would love if you get contact with us, actually, on the Mental Health Book podcast. Tell us your experience of it, because I haven't heard of a bad experience of it. But if you've had a good one or bad one, we'd love to hear about it, actually.
Definitely. So that was the Secret Psychiatrist talking about bipolar affective disorder. Once again, I found this episode extremely interesting, and I hope that you did too. If you have any questions for either myself or the Secret Psychiatrist, please get in contact with us. We are here to hopefully answer your questions. You can find us both on Twitter, Facebook, and at our websites. So for the Secret Psychiatrist, it's thesecretpsychiatrist.com. For the Mental Health Book Club, it is mentalhealthbookclub.com. If you send it through to me, it's not a problem. I can send it on to the Secret Psychiatrist. Don't forget, if you haven't already, we would love for you to share the Mental Health Book Club podcast with your family and friends. If you enjoyed the podcast, it would be so helpful if you could leave us a review on iTunes or wherever you get your podcasts. if you want to support the podcast on what we're doing financially, you can become a member of our Patreon page, which you get additional perks for being a patron of the podcast. The next few podcast episodes will be all about bipolar related disorders. So we're going to do something on postpartum bipolar disorder and also cyclothymia. And remember, it's okay to not be okay. And if you're not okay, talk. Thanks for listening to this episode of the Mental Health Book Club podcast. If you need additional help with your mental health, please contact the Samaritans on 116-123, which is a 24-hour helpline. And if you need additional information about mental health issues, please visit Mind at mind.org.uk. Our next book will be Birth of a New Brain, Healing from Postpartum Bipolar Disorder by Diane Harwood. And our next episode with the Secret Psychiatrist will be about the myths surrounding aggression and mental health. If you'd like to find out more about the MHBC podcast, please visit our website, mentalhealthbookclub.com. We really hope that you enjoy this podcast, and we would like to hear what you think. Please head over to Twitter, follow us at MHBC_podcast, or head over to Facebook and follow our Facebook page, which is Mental Health Book Club. If you would like to show your support further, please share us with your family and friends and leave us a 5-star review wherever you get your podcasts. We are now on Patreon. Please head over to patreon.com/MHBC to donate as little as $2 a month to the Mental Health Book Club podcast. As a result of your donation, you will get early access to some of our episodes, you will get specific episodes that are only for patrons, and you'll be eligible to be entered into free prize draws.